Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, you ready to talk about some anxiety?
Always, it's one of my favorite topics.
We had a great guest for this one, Dr. Jessi Gold, and a lot of practical stuff that we talked about. She really, I think the way that she talks to her patients about anxiety is really useful. One of the things she told us is that when she's talking to people and they say my anxiety or I feel anxiety, she really says that's a symptom. It can be a diagnosis, but it's also just a symptom. And you really need to clarify what they mean and what do they mean by their anxiety and really dig into how it's affecting their life so you can make the diagnosis. We asked her about using things like the GAD-7 score. I think like most of the experts we talked to, she's kind of internalized that, so she doesn't probably need to rely on a questionnaire, but I still rely on a questionnaire when I'm taking a history for anxiety. And we asked her, like, how do you explain anxiety to patients? I don't know about you, Paul, but I never really thought about explaining to them why they have anxiety. Had you thought about this before?
No, I've done my best to try to normalize it, but in terms of actually talking about evolutionary advantage, it was not a way that I
Yeah.
considered framing it before.
Yeah, so she frames it to the patients as, okay, when as we were evolving, it was somewhat of an advantage to be hyper vigilant, to have some anxiety, have some healthy amount of fear so that you didn't get killed or eaten by something. But now in the modern world, that is not really playing to our advantage, and a lot of people it's miscalibrated, where they're feeling anxiety and it's not helping them, it's not making them safer, it's making their life worse. And so she kind of explains that to people and how she's trying to help them overcome that. So we'll talk about some of those ways. And Paul, I always think about SSRIs as one of the first steps. Why she told us why not go to SNRIs as a first line?
Yeah, I was glad we had this conversation because I feel for whatever reason a little bit more comfortable with depression than I do with anxiety. But in any case, Dr. Gold reaches for the SSRIs first, in part because getting off of the SNRIs, if you need to sort of switch them, can be absolutely miserable. There can be fairly mean discontinuation effects to the extent that she's even had to sometimes bridge patients with even a benzodiazepine to get them fully off of it. So it's not the first one that she would reach for necessarily. She thinks about it more if she's tried a couple of SSRIs and has not had efficacy, or if there's a comorbid condition that might also benefit from the use of an SNRI. In the same way that you might use a TCA for someone who has got migraines and anxiety. For an SNRI, for someone who might have neuropathic pain, say, and anxiety, that might be a good medication to consider, but rarely first line, just because if it doesn't work out, getting the patients off of that medication can sometimes be a challenge.
Yeah, and she said venlafaxine was one that was specifically difficult to get people off of. But Paul, I've heard that bupropion should never be used in anxiety, and if you give it, you are a terrible doctor. What did we what did we hear about that one?
No, I mean I probably am a terrible doctor, but it's one I've hesitated, Matt, to prescribe to patients with anxiety or even comorbid anxiety. Like sometimes I'm a little bit nervous for someone who has depression and anxiety to prescribe bupropion because I worry you hear it's activating, it might make things worse. But Dr. Gold says that she's actually seen it work for some patients, so she will consider it, especially for those patients for whom the side effect profile meets their needs. So for someone who does not want to gain weight, or for someone for whom sexual side effects would be really bothersome, that person might be owed a trial bupropion because it may actually work for them. So it's not always the wrong answer. So in her expert opinion, you can try it and see how you do, just with shared decision making and letting the patient know that they may not tolerate as well as other medications.
Yeah, and she sees a lot of younger people, students, working professionals, people that are really not wanting to gain weight, and that's understandable. And so it's one of those things where she said, I will tell people, look, if you we can try it, but if you get more anxious, we might not be able to use this. We might have to use one of the first line agents that she is still recommending the first line agents, but they're just not willing to go along with it.
It was kind of we actually talked about mirtazapine during this conversation as well, and it's kind of the flip side of that coin where she says you're going to have weight gain with it. So it's
Mhm.
you have to have that conversation with the patient. If that's something they're willing to tolerate, then great, it might be worth a try. But just you have to be upfront about the potential side effects and know what the medications you're prescribing will do to patients.
Yeah. And I thought it was interesting because we asked her about, benzodiazepines, and she said she tries for her as needed medications for people who are maybe experiencing panic or, anxiety attacks. She will give them propranolol, 10 to 20 milligrams, like twice a day as needed, which is a low dose. I mean, in primary
Right.
care, we use higher doses than that than for migraine prophylaxis, or if someone's still on it for thyroid or whatever. It's still out there, Paul. You see
Yeah.
propanolol once in a
Right.
while.
You inherit
But
these patients that have been on it for 30 years. Yeah.
yeah, but the reason she uses propanolol is because she says some patients, it's more the physical symptoms of anxiety that are bothering them, and she can sort of calm down the physical symptoms with that and get by without needing to use a benzodiazepine. Well, Paul, what about the thoughts? Can we change people's thoughts with medication?
I mean, if you give enough of it, I suppose that you can. But Dr. Gold made the point, she can medicate away insomnia for the most part. You can medicate away the physical symptoms that manifest with anxiety, which can be really bothersome. So that's not nothing, but you can't medicate away thoughts and thought patterns. So that's where cognitive behavioral therapy can be especially helpful. So it's great to you can make the patients feel better with medications, but you may not be able to get rid of the persistent bothersome thoughts, and that's where therapy can be very helpful. So most of these patients would benefit from therapy if you can get them into the kind of therapy that can be helpful for them.
Yeah, I completely agree with that. But of course, Paul, we talked about so many great things with her, but we can't recap it all in this video. So please click on the link in the transcript if you would like to hear the full podcast episode. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And we'll just let that sit. And I remain Dr. Paul Nelson Williams. Thank you and goodbye.